Hi, my name's Abby. I'm one of the respiratory registrars currently at Wythenshawe, and I'm just going to talk to you today a little bit about NIV to hopefully give you a better idea of which patients we usually think are appropriate for NIV and then how to initially set them up and manage them. So this presentation has been put together by a group of the respiratory registrars and hopefully will be informative, and you'll be much more confident in approaching NIV during your rotation on respiratory. So we'll briefly go through the indications, contraindications, how to set up NIV, some of the common troubleshooting scenarios, and then how to adjust the setting on the NIV machines. So the three main indications when considering someone suitable for NIV are COPD, neuromuscular disease, and obesity hyperventilation, three of which we see very commonly coming through the Wythenshawe respiratory take. So in regards to COPD, the indications are that they have to have an arterial blood gas, a pH less than 7.35, a CO2 that is greater than 6.5, and usually a respiratory rate over 23. However, I think it's more important to focus on the gas versus just the respiratory rate. Neuromuscular disease, it's slightly softer for considering NIV. So they have to have come in usually with a respiratory illness, with a respiratory rate over 20, or if their usual vital capacity is less than 1 litre, which you can usually find on a previous letter, and they will obviously have a known neuromuscular disease where you'd be able to find that information. But they don't have to have a high CO2. It can be normal if the other two criteria are met. But usually, again, it's worth considering an arterial blood gas and looking at that pH and CO2. With obesity hypoventilation, so patients usually on an ABG should have a CO2 greater than 6 and be symptomatic, so very sleepy. And again, the same with kind of COPD and with neuromuscular disease, an arterial blood gas is key. And again, you're looking for parameters of a pH of 7.35 and below, a raised CO2 and a raised respiratory rate. But it's very important to note that NIV is not indicated in patients that have asthma and pneumonia, that have type 2 respiratory failure, because these are very indicative of severe disease, and any non-invasive ventilation should be considered in an intensive care or a more observed environment. So if you're finding that you have type 2 respiratory failure in any of these situations and the patient is for escalation, then they should be discussed with intensive care and not be initiated on NIV on the wards. So when thinking about reasons for not starting NIV, some absolute contraindications are mainly to do with whether they'd be able to tolerate the mask and whether it's safe to fit the mask to them. So that will be things like facial deformity, facial burns, or a fixed upper airway obstruction. Relative ones are when you've got a severely acidotic patient, so pH of 7.15, a low GCS, confusion or agitation, because again, these are parameters of very severe type 2 respiratory failure or someone that's very unwell. And if they're confused and agitated, you'll usually find that they won't tolerate the mask or the NIV at all. So again, when to kind of refer to ITU. So you've got a patient that's already set up on NIV, and it's really when when NIV starts to fail. So if you've got someone on an IV and you've up titrated the settings and they're on their maximum ones, and however their CO2 is still not falling, that would be an indication to speak to intensive care. Or the inability to maintain their oxygen levels. So despite in training further and further higher oxygen levels through NIV, if they're unable to maintain their SATs, then they need referral to ICU. And the need for IV sedation. So if they're really struggling to manage and tolerate NIV, and you think that they may need a form of sedation to try and help facilitate this, it's again to refer to ITU. But what's really important to remember is that some patients are put on NIV and they're not for criteria, or they don't meet the criteria for ICU, and they're for NIV as their ceiling of care. And we'll talk about that a little bit later. So when you set up a patient for NIV and they've reached that threshold where you think that they would benefit from it, you usually start with settings, or the BTS say settings of 15 and 4, and you up titrate that over a 30-minute period up to 20 and 4. However, if the patients are struggling to kind of tolerate the mask, as it can be really quite uncomfortable or unusual for them to kind of get used to the settings, you can actually start lower, and I have in the past of starting at 12 and 4, and then just giving them time to kind of sync with the machine and get used to it. For neuromuscular disease patients, you start lower at 10 and 4, and if you have a look at the NIV machine, of which there's a different presentation on, you need to just ensure that the backup rate is set to around 16 breaths per minute. The important thing is, once you've set up someone in that NIV, you need to make sure that it's working and it's doing what you expect. And you do that by repeating an arterial blood gas about 60 minutes after starting it. And you want to see, obviously, that CO2 improving and that pH recovering to normal. But what's important to remember, if you are going to up titrate the settings, that you don't go over an IPAP of 30 or an EPAP of 8 without a senior review. And it goes without saying that obviously there would be registrar and senior support for setting up NIV, and any problems you can just contact one of us and we'd be able to give you some advice if needed. So with oxygen, obviously, if you're putting someone on NIV, they have type 2 respiratory failure, and therefore you want to titrate their oxygen settings to 88 to 92%. And oxygen can be piped into the NIV machine, and this is usually by the mask. There'll be an oxygen port which you can then use to the wall and up titrate if needed. But just note that we can obviously train up to 15 litres via the NIV machine in the hospital, but at home the home style ventilators cannot provide the same amount of oxygen. So troubleshooting. So once you've got a patient set up on NIV, occasionally you might get calls to the ward from the nursing staff, or when you're reviewing subsequent ABGs, you might find that it's not improving to the level that you'd expect. And one of the first things I do is go and assess the patient and have a look at them and on the NIV mask. And the first thing to look at is if there's any air leak. You'd be able to hear that usually first of all, but then if you actually go towards the mask where the patient's, where it's attached around to the patient's face, you can feel if there's any significant air leak and adjust the mask appropriately. Because if the mask isn't fitted appropriately, then the IPAP that you're set is not actually being met. And I would also check all the way along the filter and the tubing to ensure that there is no problem with the circuit that's been set up. When you first set up NIV, you have a rough idea of which mask to fit with small, medium and large, and it may be the fact that you actually might have to increase or decrease the mask size depending how the patient's getting on. Another thing to consider is whether they need additional treatment and medication, in the view of, do they need some bronchodilators? Are they still very wheezy? Do they need some chest physiotherapy? And it's important, like I said at the beginning, to have a look at a patient and just see what their breathing's like on the NIV and whether they're synchronizing well with the machine. And occasionally, if a patient's very anxious or struggling, a small dose of lorazepam may be needed. Again, once you've done that initial assessment and you're concerned, you can always speak to a registrar or someone more senior to help. But these are some pointers for initial kind of overview of a patient if you're asked to see them. Red flags when things really aren't going to plan is when you've got a pH that's still less than 7.25, they've got new confusion, or their respiratory rate hasn't settled despite the management that you've put in place. So when we are called and asked about arterial blood gases on NIV and some of the settings that we can change, it's really relatively quite simple. If you've got a carbon dioxide level that's not coming down, then usually we aim to increase the IPAP up from what they were on. And if the oxygen levels are low or the SATs are still low, then usually we increase the EPAP. But usually these settings are no higher than 30/8. On some occasions you might need to go higher, but again, they should really be discussed with a registrar or senior if you're going above these levels. And as I mentioned before, the most important thing before even thinking about commencing an IV is the ceiling of care decision. Is this, because what you need to be thinking is, if this patient deteriorates despite an IV, what am I going to do? Are they someone that would be for intensive care and for level 2 or 3? Or are they someone that NIV, if it fails, then they would be for ward level care and to be kept comfortable? And these decisions need to be made even before starting an IV, as it gives you and your colleagues an idea of what you should be aiming for. So once you've set someone up on acute NIV and their pH is recovered, then you need to think about how to wean that person off NIV. To start with, usually we'd continue NIV for 24 hours for when the patients first started on it, and then wean down over a course of 2 or 3 days with 4 hours in the morning and at night, then usually off for the morning and on at night, in the afternoon, and then eventually overnight, with checking arterial blood gases or CBGs along the way to make sure that they're successfully weaning off NIV. What's also important to know is that once you've weaned someone off NIV, they do need a CBG or an arterial blood gas on discharge to see whether they actually need follow-up and consideration for long-term NIV. So for patients that, say, have COPD and they still have a raised CO2 at discharge, then there would be people that the Northwest Ventilation Unit would see as an outpatient, usually 6 weeks later, to reassess and to see whether they need consideration for long-term NIV. Any neuromuscular patient that starts on acute NIV, the Northwest Vent Unit will also want to know about, and probably for obstructive sleep apnea and OSA as well. So ultimately, not only do you need to have an idea of how to start NIV, but also when to then refer on once the patient's discharged. Overall, by the end of this presentation, we're now not expecting you to be able to independently start someone at NIV and troubleshoot any problems, but it's just to give you an idea of when to consider it and what kind of questions that we go through as registrars of how to manage NIV and give you an idea of overall management of it. There's also going to be a presentation linked to this of then how to appropriately document NIV and how to prescribe it appropriately.